Hello everyone, I hope this video finds you doing very well at this point in the semester. I hope you're learning a lot in this class, but also in your other classes. I wanted to just check in very quickly with a little video highlighting some main topics that you're going to be reading about in the next few weeks. So first I'll talk about the ABC model, then I'll talk about suicide, and I'll finish by talking about cultural diversity and crisis intervention. So first, the ABC model. The A stands for building rapport and maintaining rapport. Rapport is the core of the relationship that you build with the people you help. So you want to let them know overall that you're a human present with them, that you care about them, and that it's a safe place for them to come to you with their issues and work on their issues and eventually reach some goals so that they can function at a higher level. You do this in a number of ways, by attending behavior, paraphrasing, relaying back to them that you hear what they're saying, that you understand their feelings, and that you are listening to what they're saying in their own words. So you do this by showing them body language that's inviting. So you make eye contact with them, you position yourself in a way that's inviting instead of closed off. For example, you wouldn't want to close your arms in a session because that might send them the message that you're not opening up to hear what they have to say. You do other things by paraphrasing what they're saying, so making short summaries of what you hear and checking in to make sure that that's correct. And that gives them the message that their perspective is valued by you, that you care about what they have to say and their own personal experience. B in the ABC model is for identifying the problem. So this is where you will figure out why they're coming to you. If they're in a crisis situation, it might be quite obvious. But there are always underlying issues that people might have before a crisis occurs that are exacerbated when a crisis occurs. So you need to figure those things out. Surface level, what's going on, but also what's going on underneath that you can help them with. Perhaps they're in crisis because they just experienced a great loss, a death in their family, but they were already facing issues of isolation and depression. So the isolation and depression might be a secondary issue, but still something worth exploring and helping them work through. And then C stands for coping. So this is where you identify how they've coped with stressors in the past, so you can build on their strengths, but also identify new coping skills for them to use as they continue to face normal life challenges and perhaps crises in the future. Some other things that your book mentions in talking about the ABC model that might be important for you to pay attention to, one is medication compliance. So if you have someone coming in that perhaps is diagnosed with bipolar disorder or schizophrenia, it's going to be important for you to figure out if they are taking their medication so you can figure out how to help them best. It might be that they need to see their psychiatrist first, get their medications in order, and then come back for therapy if they're coming to you for therapy. Other things that might be important for you to figure out as far as medication is perhaps they're in a natural disaster and they've lost their medications, or they don't have access and they need a resource referral so that they can figure out a way to get those medications as soon as possible so they can be at the optimal level of functioning despite the crises that is outside of their medication compliance. Another thing the book mentioned is organic brain disorder. This is important to know because there might be biological components of the individual that you're working with that affect their mood and their behavior that aren't related to the crisis or the stressor that they're talking about. So it might be important that if you identify that they might have something organic going on, that you refer them to a medical doctor, but also can continue to help them with therapeutic interventions as well. So those are things to think about. Thinking outside of the box as far as biologically based issues are concerned, how they exacerbate crisis situations, and then how to use the ABC model to help clients immediately work through their experience of crisis. The next thing I want to talk about is suicide. Now, the reading that you have may be sort of confusing. So It presents suicidal clients in such a way that you would identify if they're low risk, middle risk, or high risk. I think typically when students think about working with individuals that are experiencing suicidal ideation, they become very nervous or afraid that they won't be able to help that person in the way that they need it. What I tell students is first be present with your client. Figure out what's going on, be very direct, and then you can figure out a plan of action. So you do this by simply asking straightforward, are you experiencing thoughts about suicide? Have you ever thought about hurting yourself? If you have, would you have some type of plan? How would you go about acting on that if they bring it up? A lot of people will say, well, perhaps you shouldn't ask because you're going to encourage that behavior, and that's simply not proven to be true in research. And so what I would say is simply asking and opening the door is an opportunity for you to help people, whereas asking and having them say no is not any real risk. So it's not like they're going to say no and then all of a sudden think, well, maybe I should think about suicide. That's not quite the way it works. So low risk, these are clients that may have thought about suicide in the past passively. So they might express to you, sometimes I just think life is not really worth it. And so they're not telling you, I'm going to commit suicide, I have this plan, I'm going to use this gun, or I'm going to do this thing to commit suicide. So they're not middle or high risk. They're in the low risk category. It's normal to feel desperate. And lots of people have fleeting thoughts about wanting the pain to be over or wanting life to end, and then they quickly go away from those thoughts. So those would be your low risk. They might have thought about it. They're not experiencing significant depression or substance abuse or anything that would make that situation worse immediately. You still want to check in with them, but you wouldn't act on anything. Now, middle risk is kind of confusing. So it's like low risk. They've thought about suicide, but what sets them apart from low risk is that they might have some exacerbating condition going on too. So not only have they thought about suicide, but maybe they're also severely depressed and it's getting worse. Or maybe they're using alcohol and they're drinking more often or larger amounts. So you want to think about things that impact their suicidal ideation as well. This would put them in the middle category. Thoughts about it, exacerbated by emotional issues that can make it worse, but not a specific plan. You might talk with them about how they might keep themselves safe and create security in your relationship, but you wouldn't move to hospitalization necessarily yet. Now, high risk is when your client comes in and tells you that they're thinking about suicide, they have a specific plan and the means to do it. For example, you might have had a depressed client that's getting more depressed, thought about suicide in the past, and they'll come to you and say, I want to kill myself and this is how I'm going to do it. I'm going to hang myself in my grandpa's barn with a rope that he has. Very specific plan, the means to do it. This is scary and it's maybe overwhelming, but you have to reframe it into seeing it as an opportunity for you to help your client and evidence that they trust you to help them and that they want help. So I just have some tips for you if something like this were to ever happen to kind of help you get through it, because it often does happen in the helping professions. So first, always ask directly, have you thought about hurting yourself? And they might say yes. And you say, have you ever thought about how you might do that? And they'll say, no. Or, yes, actually I have. So you just want to explore that. Don't ever run from it or dismiss it or not take them seriously or be too afraid to talk about it, because they want to talk about it if they're talking about it with you. Express empathy. So you might not know what it feels like to be suicidal, but you might know what it feels like to be really sad or really disappointed or really angry. So you can kind of meet them in the place that they are, despite not having the same exact experience, and that will comfort them Remind them that you're here with them, that you'll work through this together, so they know that they're cared about, that they have someone who supports them, and that you're not going to abandon them or simply send them away, that it's a collaborative effort and you'll be there with them so they don't have to be scared of seeking further treatment. Talk about hospitalization. And so if they say they have a plan and the means to do so, then it's your responsibility to make sure that they're hospitalized. So you will talk with them about that, and you should have already in your informed consent when you started talking to them in the beginning. So you might say there's voluntary and involuntary hospitalization. Voluntary is when you talk about it with them and they agree, yeah, I think I do need help. I'll go to this psychiatric hospital or to this treatment facility. And then you just walk through the steps with them, calling someone, arranging transportation, calling the hospital to set them up for an intake. Involuntary is very rare. Sometimes clients, for whatever reason, will not want to go to the hospital, but it's still your responsibility to make sure they get there. So you will communicate that with them, and then you might have to resort to calling the police or public safety for help in helping you getting clients. This is not typical. Typical clients will come to you if they express suicidal ideation with a plan and the means to do so. Then they want help, and they're open and receptive to that. So you identify next steps after that. Maybe perhaps you need to call the police. Perhaps you need to call some type of other transportation and call the hospital or the treatment facility and consult. So often you'll work in an agency or somewhere where there's other people that are helping professionals like you. So talk to them. Get their input, enlist their help, talk to your supervisor. It's really a team effort when someone feels suicidal and they need help. So you're never alone in that. And then also the last step is to make follow-up plans. So you want your clients to know that you want to see them when they get out of treatment, that you want to build on the hope that they have. Maybe they're suicidal, but they have a really strong relationship with a family member that's important to them, that will give them a little bit of hope or something that's going well. There has to be something in their life that they can hold on to. So you want to talk about that and also express to them that you will see them after they get through treatment, so they see that hope at the end of the tunnel as well.